the objectives of this lesson will be, first of all, to define blood banking, then discuss the structures of blood banking, discuss the history of blood banking, describe what is hemovigilance, and then what are the applications of blood banking. Now, blood banking is a process, of course. The fact that it has an ing, because also it's good to be able to define a blood bank. So blood banking is a process that takes place in the lab to make sure that donated blood or blood products are safe before they can be used in transfusions or any other medical procedure. So it is that process that will take place in the lab, and that process, of course, will involve a lot of laboratory testing, and that is why this is very important for us as MLS. So that process makes sure that the blood and blood products are safe before they can be transfused. And the establishment of where this procedure takes place, of course, now is the blood bank. We also have some other concepts that may be used from time to time within blood banking, like what we call immunohematology. And this is the study of blood-related antigens and antibodies as applied in now blood transfusion and also in hemolytic disease of the newborn, because most of the time, most reactions will be antigen-antibody reactions, like we have done that recap. Okay, then we have what we call hemotherapy. Chemotherapy refers now to the selection with preparation and infusion of appropriate blood or blood components or their derivatives for each individual patient. So here we are treating patients, so we need to select and also prepare what is the appropriate blood or blood component or blood derivatives for each individual patient, because when we do blood banking, people will be waiting, or patients will be on the waiting list for this blood and blood products. So we need to keep matching them to the correct patient so that they can be treated. Now, of course, this you have done before. The concept of blood groups, very important. We actually have so many blood groups, or about 30 blood groups based on the red blood cell antigens. The major ones, of course, is the ABO. We have the Ressers, we have Kell, Lewis, Duffy, Kidd, Colton, and so many until 30, around 30 of them. But the most important usually are ABO and Ressers, because they are highly immunogenic and therefore they are easily recognized by the patient serum, so that now we have to check for compatibility to ensure that there is no transfusion reactions. And of course, this table is what we were trying to, what I have just done there when we were doing recap of what the patient blood group is, what donors they can have. And I think you have already interacted with this table a lot. And in this table, the takeaway message is that blood group O is a universal RBC donor, because they usually will not be having any antigens on the red blood cell surface, and therefore the patient or the recipient does not produce any antibodies now that they have no antigens. And of course, now blood group A is the universal fresh frozen plasma donor. And of course, being a plasma donor, it is because they do not have the antibodies. They have no ABO antibodies. Now, the blood components are important because in blood banking, you realize that not every patient needs whole blood. So we also do other blood components for different patients and match them differently depending on what the patients require. Now, one of them is the red blood cells. Of course, we know they are very important for oxygenating the tissues, and they can be used in the treatment of anemia. And then we have platelets, very important because of blood clotting. So for individuals with leukemia and cancers, very, very important. And then we have what we call white blood cells. They help us in fighting infection and they aid in the immune processes. And then we have, of course, the watery liquid part of blood called plasma that helps us maintain blood pressure, provide proteins for clotting, and balances the electrolytes within the blood. And then we have what we call cryoprecipitate, and most of the time we call it cryoprecipitate antihemolytic factor, portion of the blood, and it contains the clotting factors that can help in controlling bleeding in patients who are having bleeding issues. And then we also do have albumin, immune globulins, and clotting factor concentrates. So that you just extract albumin from the blood, you extract IgGs, that is the immunoglobulins, IgM, IgE, depending on what you want, and of course even other many clotting factors. We have factor 8, factor 7, etc. And those can also be separated and processed for transfusions. So all of these blood components, of course, usually come from whole blood. Okay, so you can see like this picture here that you can see this. The first one is packaged red blood cells, the second one is platelets, the third one here is fresh frozen plasma, and the fourth one here is cryoprecipitate AHF. And we will be looking at what are these bags, how do you identify these bags, what are the anticoagulants that we use in this case, etc. And of course, each of these components also need to undergo what we call a TNS, which is a pre-transfusion laboratory test that consists of ABO and results testing, along also with antibody screening. Now, we have what we can call a blood banking structure or process of how blood gets into the blood bank and how it exits the blood bank. How does that process or structure looks like? Now, this structure will include processes of collection, processing and preservation, also preparation, and finally distribution of these blood and blood components. So I have used this um, pictorial here to help us summarize this. So of course, at the receiving in a blood bank, we will be receiving the patient as well as the donor specimens. Once we receive them, now you can see the purple arrows. Once we receive that, we prepare them. Okay, prepare them will also include what are the anticoagulants, and then after that we do testing, the ABU, the cross match, and other tests that we will be outlining in subsequent lessons. And then we also receive blood products in, because they could also be coming from another blood bank. You know, blood banks have levels. Those that are in district hospitals, that are in national hospitals, etc. So we can also be receiving blood products in that have been collected even in community setups, and then they will be received again, and then of course they will be stored. And now after the storage of blood products, then of course we are going to be having their distribution, and of course also distribution preparation. As you distribute them, you know, you could make sure that all the other processes are well, and that's why we do quality assurance. And then you also make a mistake at the distribution, so we also do have distribution preparation to make sure that as you dispatch these blood products to the patients, they are being distributed in the correct format, in the correct temperatures. We talked about cold chain management and so on. So this structure simply helps us to see how do we receive, how do we store, how do we prepare, and when we get orders, how do we distribute our blood and blood product components as well as derivatives. You may be wondering, where did blood banking start? Because like you can see in this picture here, in the past, blood used to be transfused directly from the individual giving, who is this donor here, to the patient, who is the recipient. It used to be done directly. And you can imagine now how many issues there used to be in the past, because this blood has not been tested, it has not been made compatible, nothing has been done, even for screening of, you know, viral diseases and other diseases that could be there. So in the past, this was how it used to be. So blood banking has a history, and in the development of blood banking can be dated to in the 1915. And it was when this guy called Richard Lewison of Mount Sinai Hospital in New York initiated the use of sodium citrate as an anticoagulant. So that now instead of doing direct vein to vein, at least you can be able to first get the blood from the donor, store it in this sodium citrate, and then now do blood transfusion. And then there was also an introduction of what you call citrate glucose solution by Francis and Turner 2 years later. And this permitted the storage of blood in containers at least for several days. Okay. And now this opened up for the first blood depot, what was called the blood depot, that was established in Britain during the World War One. Of course, now around that time, when there was war, there was a lot of bloodshed and accidents and all that needed there to be some stored blood for transfusion into casualties. So you can see that we started with direct vein to vein, and then we developed some anticoagulants, and we were able to develop a blood depot. And then 3 years later, after that, there was the introduction of acid citrate dextrose solution that was discovered to reduce the volume of anticoagulant. They were not using as much anticoagulant like before, and it also permitted transfusions of greater volumes of blood and also longer term storage, more than a few days. And then there was this that was introduced, the anticoagulant preservative CPDA1 that was introduced in the 1979. This helped us decrease wastage from expiration of blood and also facilitated resource sharing among blood banks. I talked about blood banks, different levels as well as in different regions. And then newer solutions that contained adenine were produced, and they extended the shelf life of red blood cells to 49 days. That is more than a month, which was very good. And that helped, of course, to be able to, have red blood cells that can be used in case of any emergency across the state. And then, of course, within a few years, hospital and community blood banks were established within the United States. And then this Johann organized the first blood bank in Europe in the 1940s. And an important breakthrough also occurred in the 1939 to 40, where Karl Landsteiner and his colleagues Alex, Philip, and Stetson discovered the Rh blood group system. Of course, now this was one of the major causes of transfusion reactions up to around that time. Of course, today we have discovered many other transfusion reaction causes, but at this time, these men were able to at least describe the rhesus factor or the rhesus blood group system. So as far as the history is concerned, that is the development mainly of anticoagulants, then of course discovery of the rhesus factor, and today we have the discovery of other antigens, not necessarily on the red blood cells. We also have HLA, which we also do HLA typing and so on and so forth. So there's still a lot that is being discovered in the effort, especially to curb any transfusion reactions. And on that note, this is now where this term hemovigilance comes from, because at the end of the day, we must ensure transfusion safety. So this hemovigilance is an element of transfusion safety that involves several surveillance procedures that are carried out from the time blood is being collected at the donor stage, during the entire component processing chain. How do you store that blood? How do you transport it? And then also after the recipient has received this blood, doing a follow-up. You do a surveillance on the follow-up of the patient to ensure that they are safe. So the purpose of hemovigilance, usually because we've said it starts from collection, helps us to maintain awareness of blood transfusion requests. So we are able to note what are the orders that have been done. Then, of course, promote blood safety and prevention of adverse events. And then we have identify weak and underperforming areas of transfusion, because it's doing a vigilance from collection up to after the patient has been transfused. So we can tell, is it at blood collection we have a problem? Is it at the laboratory we have a problem? Is it at the hospital setup where now the patient is being transfused, etc. Of course, help us recognize incidences of adverse reactions, and then provide a method for documenting and investigating transfusion reactions, and overall ensure safe and efficient use of blood. Okay. Now, in an entire blood banking system, we are going to be recruiting blood donors as one of the functions. We are also going to be collecting, storing whole blood, as well as the blood components that we have talked about earlier from volunteers and also from donors. And then we're also going to be now as MLS, working in blood banking, do typing, do screening for infectious agents, and also prepare the patient and the donor for blood transfusion. And then we will also be detecting and identifying antibodies in potential blood recipients, or also in pregnant women in the cases of hemolytic disease of the newborn. And then we have establishing a database to support suspected or even potential disorders. And finally, be able to process, disperse blood and blood components.